So it's my privilege to introduce our next session, which is a panel we're calling Network Perspectives. Last year we introduced this session because we were challenged by, actually among our board, that WFN shies away from tough issues. So we introduced this session last year when we took on the issue of sex trafficking. And that actually, it led to an audience revolt. So hey, it was tough, right? So, and at the time we chose to start off with that, there were many reasons. At the same time, we chose that the second follow-up tough issue would be reproductive health. And that was even before the firestorm of all what we've experienced over the past 2 years, which made it a nice convergence of it being a timely topic and current, and have us all really engaged in something that's really important to us today. So we wanted to take on this tough issue not from the perspective of having a debate on one side of an issue or another, but to allow us as a community to take a deeper dive into the complexities of these issues. So can we appreciate the scope of issues and how it's being experienced in different contexts, both here in the US and in many different countries around the world. Certainly the sex trafficking issue has a lot of complexities and different perspectives and experiences across cultures. How do we engage funders and the funding community in these issues, both individual and institutional funders, to make sure that they are effectively investing in this work so that we can arrive at solutions, break down barriers, and really have the capacity to confront these issues in our communities. So this is sort of the frame of Network Perspectives, and we'd welcome suggestions from all of you for future topics that are current, that are complex, that we're all challenged with, both as funders and also as activists, so that we can continue to build our capacity to confront tough, wicked problems, as we've learned about so much this week. So now it's my real pleasure to help us have this conversation with three folks who have a lot of experience from different ways dealing with the issue of women's reproductive rights and justice. So let me introduce to you Anu Kumar, the Executive Vice President of IPAS, that deals on a global space around abortion rights. And she's in the center. I'm not even doing this in order, am I? On the far right is Jamie. Jamie Bardwell is the Director of Programs at the Mississippi Women's Fund. Thank you for joining us, Jamie. And then here, closest to me, is Heather Boonstra from the Guttmacher Institute. And anyone who's worked in reproductive health, reproductive rights, knows Guttmacher, who's kind of been that place where they're tracking the data and giving us the tools to actually have these conversations. So welcome to each of you. And we are going to hear from them. They're going to come up and tell a little bit about their role, their organization, and how they deal with the issue. But before that, I want us to just look at the definition that's up on the screen. This is there, even within WFN world, there's been a lot of diversity in terms of even the definition of what we're talking about. So WFN came up with this definition of reproductive justice. And the reproductive justice movement is a transformational approach to advancing reproductive freedom and women's rights. It addresses the full spectrum of reproductive issues that impact women's lives, including the right to access reproductive health information and care, bear and parent children, receive treatment rather than incarceration for substance abuse, access a safe and legal abortion, live free from violence, and live and work in an environment free of reproductive toxins. So you can see there's environment, there's violence, there's drug abuse, all these things, even within the context of reproductive rights. So we might invite the complexity beyond our capacities, actually. But I offer you to reflect on this and kind of include that definition in our conversation, and what your take is on it and what your thoughts are about it. So with that, I'm going to move over here and invite Jamie to come up first. We're starting with Heather, I'm sorry. Heather's going to talk about and sort of lay the framework from a data perspective. Heather, come on.
Well, thank you for having me here today. My extended family is actually in Michigan, so it was nice to come to this state, and actually they are here. But I always enjoy the lakes and rivers and outdoor things that Michigan offers, as well as its cities. I do come from the Guttmacher Institute, and you might know the Institute. We're a not-for-profit corporation with headquarters in New York City and probably best known for our research. But we also have offices in Washington, D.C., where we monitor state policies across the board of sexual and reproductive health issues. And we also work on federal policy issues and translating that research into workable action steps for policymakers. And so I was asked to present just briefly on how the Guttmacher Institute uses policy research and analysis to advance women's reproductive health and rights and justice, and then also give us a grounding in the facts and figures, both about women here in the United States as well as globally. And then maybe during the discussion, we can talk about what are the more effective strategies for ensuring that evidence and analysis are given to the relevant decision makers and stakeholders that there are in our communities. So the Institute's overall arching goal is to ensure the highest standards of sexual and reproductive health for women and men worldwide. And this is based really in a theory of change that says that scientific evidence, when it is rigorously collected, compellingly presented, and systematically deployed, can make a difference in policies, programs, and healthcare practice. And to that end, our programs have always been this unique marriage of policy-relevant research on the one hand, strategic communications when that research comes out, and then also analysis and policy making that flows together in this kind of spiral of never-ending questions that are answered through research and then communicated, which in itself raises new questions for the policy-making process. So looking then at sexual and reproductive health in the United States, most Americans want small families, and the typical woman today wants just 2 children. And in order to get there, most women practice contraception. In the United States, contraceptive use is nearly universal, with 99% of women using it at some point in their lives, and 89% of women who are currently at risk of an unintended pregnancy who are currently using contraceptives. The benefits of contraceptive use are well documented and known, both for mothers, for newborns, and for families and communities. Pregnancies that occur too early or too late in a woman's life, or that are spaced too closely together, negatively affect maternal health as well as the health of her infant. But when used correctly, modern contraceptives are extremely effective at preventing unintended pregnancy. The 2/3 of US women who are at risk of unintended pregnancy who practice contraception and use it consistently and correctly over time account for just 5% of unintended pregnancies in the United States. But achieving this goal of preventing unintended pregnancies and keeping families small is no easy task, and a typical woman spends about 5 years pregnant, postpartum, or trying to become pregnant, and 3 decades of her life trying to avoid an unintended pregnancy. And contraceptives can be very difficult to use consistently and correctly over 30 years of your time. And thus, unintended pregnancies are very common. And about half of all the pregnancies in the United States are unintended. And that translates into roughly 5% of reproductive age women have an unintended pregnancy each year. And by age 45, more than half of all American women will have experienced an unintended pregnancy, and 1 in 3 will have had an abortion. And although unplanned pregnancy affects all types of American women, a greater proportion of women of color, women who are young, unmarried, and poor, become pregnant when they do not want to be. And most significantly, unintended pregnancy is becoming increasingly concentrated among poor women, as this graph shows over time. And compared to higher income women, poor women have unintended pregnancy rates that are 5 times as high, they have abortion rates that are 5 times as high, and they have unplanned births that are 6 times as high. This slide, the next one, shows that women of color bear a disproportionate burden of unintended pregnancies, abortions, and unplanned births. Black women have the highest unintended pregnancy rate overall of any racial or ethnic group, and it's more than double that of non-Hispanic white women. And because rates of unintended pregnancy are high, rates of abortion and unplanned birth are also very high. And this in itself reflects broader social and economic disparities around education, employment, and access to healthcare generally. Now turning to the global context, it's important to note that this long-term trend that we've seen of women wanting smaller families is not just a US phenomenon, but a global phenomenon as well. And just like their sisters in the United States, most women in Latin America, Asia, the Middle East, and North Africa generally want just 2 or 3 children. Women in sub-Saharan Africa still desire larger families, but even there, women want fewer children than their mothers or their grandmothers did. And what we've seen globally is that there has been some progress in unintended pregnancy, that unintended pregnancy has declined, at least slightly, in all major developing regions since 1995, and this is overwhelmingly due to contraceptive use. And you can see from this graphic, however, that unintended pregnancy remains unacceptably high. Rates in developing countries, particularly in Africa and Latin America, remain much higher than they are in developing nations. And when unintended pregnancy is high, abortion rates are also high. Women in all parts of the world, of course, have abortions, and they have them for very similar reasons. They cite concern or responsibility for other individuals in their lives. They say they cannot afford to have a child or another child. And they say that having a baby now would interfere with their other goals around work or school or the ability to care for other children in their lives. The world's lowest abortion rates are in Western Europe, where the procedure is legal and widely accessible, but where effective contraceptive use is very high and unintended pregnancy is very low. Some of the highest abortion rates in the world are in Latin America and Africa, where abortion is highly restricted in almost every country, but where many women have unintended pregnancies. So this is to say that making abortion illegal does not stop it from occurring, it just drives it underground and makes it more unsafe, where women have to undergo risky procedures from untrained providers and under unsanitary conditions. And this slide shows just what those consequences are, and they are quite horrific. Every year, 47,000 women die from complications of unsafe abortion, and millions more are injured. So in my final slide, I just wanted to come back to the definition of reproductive justice that was laid out at the beginning and look at the ways that it addresses the full spectrum of women's lives in terms of the right to access reproductive health care, bear and parent children, and access safe and legal abortion, and live free from violence in our lives. And this definition really encapsulates this link between reproductive rights and the social justice arena. It brings special attention to social, political, and economic inequalities, and it really challenges us to think of women's lives more holistically across a diversity of issues that might really impact the decisions that women can make about their reproductive health. And I think that we'll talk more about our discussion, in our discussion about the policymaking process in which I work, because my slides really have outlined the problem and made the case for why we need to address women's sexual and reproductive health needs, but that doesn't bring us yet to solutions and what is the role that the government can play in helping women have better control over their reproductive lives. So I look forward to that discussion. Thank you today.
Thank you, Heather.
Yeah.
stand up? Okay. Thank you so much, Heather, for setting the data context. Now I want to invite Anu up from IPAS to talk about what IPAS work and their role in this issue is.
Thank you. Good morning, everyone. Thank you for hanging in there until Friday morning. And I want to really thank the organizers for having this session, for organizing this very interesting panel, and for inviting all of us to contribute our thoughts. Detroit is actually very near and dear to my heart. When I first immigrated from India, I actually immigrated to Windsor, Ontario, across the river. And so I went actually last night to see my family there. So I was delighted to have a reason to come to Detroit.
Great.
So in thinking about reproductive justice, I was reminded of a quote from one of the great leaders in our field in global and reproductive health and rights. Do I have to lift this thing up? Here we go. Dr. Mahmoud Fatala. Dr. Fatala is an Egyptian OBGYN and leader. And when he said this when he was talking about the issue of maternal mortality. Maternal mortality around the world happens to be one of the health disparities that is the most pronounced between developing and developed countries. I think, to me, this quote actually really summarizes why this is, in fact, a social justice issue. Women aren't dying because they must die, because we don't know what to do. Women are dying because we have not deemed their lives are worth saving. We actually know how to prevent these deaths. Women in the United States do not die, fortunately, from pregnancy and childbirth. But around the world today, every 90 seconds, a woman does die in pregnancy and childbirth. So we must, I think, decide that their lives are worth saving and move towards actions that will save them. Just briefly, let me tell you a little bit about what IPAS does. I hope some of you have been by our table, which has been outside for the last several days. IPAS is an international reproductive health and rights organization. We really work to provide access to safe abortion care. We don't actually provide services, but we work with health systems around the world in training providers and others to provide safe, comprehensive abortion care, including access to contraception. We work in the legal and policy environment to create an environment that is supportive of women's health and rights. And we are 40 years old, actually. This is our 40th year. We were founded in the same year as the Helms Amendment was passed, and we shall return to that fateful year later. So Heather gave us an overview of the situation globally and also the situation of abortion. There are 40 million abortions that take place around the world every year, and you've seen these statistics already. I just want to make a note that the numbers are slightly different because the numbers are actually not that great. It's not so easy to find these numbers and to get them and to collate them. But the Guttmacher Institute is obviously a huge help to us and a terrific partner in making sure that we have the best information possible. The thing that's really striking about this to me is that the deaths that are occurring, the vast majority of them are occurring in the developing world. And even there, the majority of those deaths are occurring in Africa. So we have a concentrated problem, and we know where it lies, and we know what we need to do about it. The other thing is that everyone is at risk. So at IPAS, we approach this issue as a public health problem, and that's because every woman is at risk when she has an unintended pregnancy. Every woman everywhere. And so it's not, the problems are not randomly distributed. They're concentrated in particular locations. So what do women do? I'll just pause for a moment and let you read this quote from my colleague, country director in Nigeria, about what women do when they are faced with unintended pregnancies in Nigeria. This was testimony that Dr. Oji gave in front of the U.S. House Committee on Foreign Affairs when we were working on the gag rule. Women will literally do whatever it takes to end a pregnancy that they do not want, including risking their health and lives. So this slide comes from the Center for Reproductive Rights, which tracks the world's abortion laws. And as Heather mentioned, having the legal framework is extremely important to access to safe abortion care. Unfortunately, it is not sufficient. Of course, it's very important to have legal access, but as we see in the United States, the chipping away of the legal right to abortion has deep consequences. So, and unfortunately, that's not just in the United States. We also see this in India, where there is a legal right to abortion. However, the restrictions are so constraining that access to safe abortion care is still not a reality for the majority of Indian women. In fact, between 1950 and 1985, nearly all industrialized countries liberalized their abortion laws. And then in 1994, we had, some of you may remember, the International Conference on Population and Development, where the world's community actually gathered and said, yes, we believe that access to safe abortion care is important, and we confirm and affirm that right. And since then, we've actually seen tremendous progress around the world. 25 countries have actually liberalized their abortion laws since 1994, including countries as diverse as Ethiopia and Nepal. And in both of those countries where IPASS is active, we are seeing the widespread availability of safe abortion care to women in all areas of these very rural countries. But there are a handful of countries that have actually moved backwards since 1994, and it will not surprise you that the United States is on that list. So we have a lot of work to be done, and not only domestically, but we have a lot of work to be done in foreign policy. And I was really heartened to hear Michelle speak yesterday about the need for one global women's movement. It's not helpful to have a division between the rest of the world and the United States. And one example of where our policies are harming the world's women is in our foreign policies. So most of you will be familiar with these, I hope, with these two policies, the gag rule and the Helms Amendment. They're often conflated with each other, so just a brief explanation of what the gag rule is versus the Helms Amendment. The gag rule, you will remember probably, that is this political football that gets thrown around depending on who's in office, right? So at the moment, the gag rule is not in place thanks to President Obama, but should there be a change in leadership in the future, there is likely that the gag rule will be reinstated. So the gag rule stipulates that foreign NGOs, foreign non-governmental organizations, who receive funds from the U.S. Agency for International Development, cannot then use their own funds to provide abortion services, counseling, referral, or advocate for less restrictive laws. So this is not actually a constraint on the use of our money, it's the constraint on the use of their other money. This is in contrast to the Helms Amendment, which has always been there, has been there since 1973, has not changed, has remained in force, which has prohibited the use of U.S. foreign assistance funds to pay for the performance of abortion as, quote, a method of family planning. So there's never been a definition of what that means as a method of family planning. So without that interpretation from the State Department, organizations have interpreted the Helms Amendment to mean a complete and total ban on any payments for any abortion services. In fact, IPASS, Guttmacher Institute, Planned Parenthood Federation of America, and others are working together to reinterpret the Helms Amendment. What we would like is for the Helms Amendment to at least come to the, by my standards, fairly low standard of the Hyde Amendment, which you also recall exists in the United States. This is domestic ban on abortion funds. We would like the Helms Amendment to, like the Hyde Amendment, to permit the use of U.S. government funds to pay for abortions in cases of rape, incest, or when the life of the woman is in danger, for example, in conflict settings. I personally don't think that's a particularly high bar, but that's the bar we're aiming for at the moment. A reinterpretation of the Helms Amendment, not in fact a repeal, which would be ideal. But I just wanted to remind us that these policies are the policies that our government has instituted, and these policies are having such a damaging effect on the lives of millions of women around the world. IPASS has done some research on the Helms Amendment, and we have a flyer outside summarizing some of the research of the impact of the amendment. So the impact of these policies are, of course, this very restrictive interpretation. But I think for you as a donor community, the thing that's really interesting is that the US government is actually the single largest donor in our field. So to have the US government stipulate these conditions on its funds is very damaging, not just in terms of financial loss to organizations, which is significant, but also it denies access to equipment, supplies, technical assistance, and I mean equipment and supplies like contraception. You know, just very basic equipment and commodities are denied to organizations. We've even seen censorship of research and advocacy materials as a result of the Helms Amendment, and of course increased stigma. So I want to talk a little bit about stigma because I think it has an impact on what's happening in our community and on these issues of reproductive justice and abortion in particular. IPAS has been doing a fair amount of work on stigma of late. We have done some thinking around what is abortion stigma and have defined abortion stigma as a negative attribute that's ascribed to women who seek to terminate a pregnancy and that marks them as inferior to the ideals of womanhood. There are many ideals, aren't there? We think of stigma as operating in multiple levels, from the framing discourse down to the individual level. And you can see that in the framing discourse, we have, if you read media reports, particularly around the world, you'll see women and providers being described as murderers, as being stereotyped, as promiscuous, as, you know, or worse. So the language that we use really matters. You see stigma, I think, operate at the government level, and I think, in fact, that the Helms Amendment and the gag rule are manifestations of stigma. They are legislating stigma. We see organizations that have to separate out abortion services from the rest of their services, when in fact we all know that abortion and reproductive health and women's health should be holistic and in a continuum of care. And then of course we see abortion at an individual level, or a stigma at an individual level, which impacts communities and societies at large. The consequences of this stigma can be severe, and I'll just let you read through this diagram, but ultimately it can result in the context where IPAS works around the world in delays in seeking care, and as you know, every day counts when you're looking to end a pregnancy, resulting in high costs, abuse. It can result in death, even suicide. And lest we think this only happens in the United States, I just want to remind you of a case in Idaho of Jenny McCormack, who was a woman living in rural Idaho who had no access to a safe abortion provider, or the nearest provider was in Utah, several hours away. She essentially had to delay getting the care that she needed, and actually was arrested. So in fact, I was thinking yesterday, I need to modify this slide and put in arrest and prosecution. As I mentioned, we're doing some research on this topic. Here are some quotes from voices of men and women as they're talking about stigma in Ghana and Zambia. The one that was really striking to me is the third one, which says, "Someone who aborts doesn't deserve a handshake, as they would disease you." Literally in Zambia, we have found that people believe women who have had abortions are contagious, and they must be confined, and they must be avoided. The stigma is so palpable that they're wanting to essentially quarantine women who have had abortions. So we're engaged in research in the creation of an abortion stigma network, which we invite you all to join, and in creating and reducing stigma reduction activities. So how does it affect you? I'm just going to leave you with these two questions, and I hope we can discuss them more during our Q&A time. How does abortion stigma affect each of us personally? And how does it affect us as donors? And how do we communicate about this topic without further stigmatizing ourselves and others? Thank you.
Okay, good morning. I've got 7 minutes, so we're going to do this quick. So I'm here to talk to you about how you do this work in a place like Mississippi and still open the doors. Okay, so this is Mississippi's state flag, just to remind you in case you didn't know that we're a conservative state, and that's the Confederate flag in our state flag. So that's the backdrop in which I'll talk about this work. In 2011, Carol, the executive director of the Women's Fund, and I sat down and we said, no one's doing this work on teen pregnancy prevention in Mississippi. We have the highest teen birth rate. We have to do something. And so I just got on the phone and called everyone I could possibly think of, including Guttmacher, and asked for advice and said, how do we tackle this problem? And they said, you have to talk about economics. And I knew our legislature, I knew our politicians, and I knew if we didn't talk about it in terms of money lost, no one would listen. So we produced a report in 2011 on the taxpayer cost of teen births. And we partnered with our local economic policy center, and it got all this great coverage. And we were so surprised because we thought no one really outside of Mississippi cared, but they really did care. And the report really changed the conversation about teen pregnancy in Mississippi. And we had Governor Barber, as he was leaving office, said he read the report, and the next day after it was released, he said the number one thing he would do if he could snap his fingers is to reduce the teen pregnancy rate in Mississippi. We thought, wow. And he's actually a lot more progressive on it than you would ever think by what he says, but that's another story for another day. And so we really wanted to change the discussion, and we also wanted people to understand that this is not this unsolvable problem. There are things that you can do that make a lot of sense, and so we put these concrete solutions in this report. And then we decided, well, if we're going to put these solutions out there, we should really put our money where our mouth is and actually fund these solutions. So the first two are what you really consider more reproductive health issues. Teen-friendly health services, basically what we're saying is teens need to have a place to go to get reproductive health care, and their parents won't get a bill in the mail. It's really, really difficult to do this. If you've got Medicaid, they send home an EOB. If you've got private insurance, they send home something. So it's really difficult, and most teenagers do not want to go to a Department of Health family planning clinic because they aren't really convenient to them, or they live in Mississippi where there's 50 miles between them and the next clinic. So that's number one. Number two, advocacy for comprehensive sex ed. Mississippi passed a law in 2011 that said everybody's got to teach sex ed. Abstinence only or abstinence plus, choose one. Now, abstinence plus is just like abstinence only, really, but it's progress. I'll take it, you know. Come down to Mississippi and you'll learn a lot about what you'll take as some progress. So here's the good news and the bad news. Of these things that we funded, there's three things. The access to opportunity is really our more mainstream grant making, you know, youth leadership, IDAs, job training, the stuff that people feel good about, you know, foundations in Mississippi are like, we like to educate young children, that's good. So that's that. And we have $506,000 in grant making that we committed last year for over 2 years. And of that $506,000, $65,000 is for the first two issues that you see here, the more reproductive health focused issues. So the good news is we have $506,000 in grant making. The bad news is that only $65,000 is for that, and because so much of this money is restricted, and it's really, really hard to raise money for reproductive health in Mississippi and really anywhere else. So before I talk about the challenges, I want to say a quick word about some of our successes. And starting on Monday, we have joined a partnership with the University of Mississippi Medical Center to open the very first teen-friendly health center in Jackson. And it's super exciting. And I can tell you all about I knew the healthcare system was broken before we started on this project, but I can really talk to you a lot about how it's really broken after this. So what we did was we are funding for $41,236, 10 months of nurse practitioner time between the hours of 4:30 p.m. and 7 p.m. to only see teenagers at an urban health clinic in Jackson, Mississippi, housed within an existing clinic. We didn't have to build the clinic, we're just funding those hours. And it's free, it's confidential, it costs this extra money even with Medicaid reimbursements because we have to eat the cost so that it is confidential. So that's why it costs that kind of money. We have funded for 3 years in a row an advocacy group called Mississippi First to get school districts to adopt an abstinence plus policy. 47% of our 152 school districts adopted an abstinence plus policy. If you go look at the Huffington Post, they say no one in Mississippi is adopting abstinence plus. 81 adopted abstinence only. They don't tell you that there are 152 school districts and 71 adopted abstinence plus. So we got on the phone with them, and I got really angry and I said, you got to tell the real story here. I know it's easy to beat up on Mississippi, but you're not helping anyone's case here when you keep on reiterating this same sad story about Mississippi. 47% adopted abstinence plus. They corrected their story. So it's things like that you know, you have to be on watch. I won't go through the rest of these, but we were really frustrated with the lack of sexual health information in schools, so we created factnotfiction.com with our State Department of Health, and it's the only medically accurate sexual and reproductive health website for Mississippi teenagers. They can go in and find health services nearby. It's really cool, so please check that out. So the challenges. This is the good stuff. So you all know we have a very conservative state, but we also, nonprofits in Mississippi really lack the capacity to do a lot of the work that we want to fund. And so as a consequence, we have to do some of this work. Like as a funder, I should never be telling some nurses how they should run this clinic, but they had no idea that Medicaid's going to send home a bill. So how do you do this work when so many people aren't exactly sure what the problems are? So we operate in this kind of touchy space. And we oftentimes have money that we can't give away, and that's also an awkward place to be as a funder. Operating money and individual donations are really tough. We can get $500,000 for education of young children, but we struggle with getting $50,000 for basic preventive health services. This is just the way that it is. And then lessons learned. So the irony here is not lost on me that Cecile is in the front row and I'm about to say that abortion is not in our vocabulary, but it's really a point of strategy. We work with Planned Parenthood behind the scenes. We understand the issue so much, and as someone who is very, very progressive, this sometimes really hurts. I mean, it sometimes is tough to not speak out on some of these issues, but we really do it from an issue of knowing that in Mississippi, we have to maintain really strong message discipline. Reporters know if they call and ask me about abortion, I will talk all around it, and I will talk all about comprehensive sex ed and access to birth control, but I'm not going to talk about abortion. It's just the way it is, and we still have to open up our doors. A strong board has really made us successful, and Carol really gets all of the credit for this because she has formed this board that is completely behind us, and they are very educated on these issues. They are not a corporate board. They're not where we get most of our money, but they're really smart, very diverse, and they are behind us every step of the way, and they have really made the biggest difference in our success on this work. We really started small with this report, and we really built from there, and we finally claimed ourselves as experts. The press kept on calling, and I would say, call somebody else. And they kept on calling, and I was like, I am an expert on this, and I will tell you all about what we think are the solutions. So really claiming that expertise was a huge step for us. And then the last thing I'll say is that data is so important, and we use Guttmacher data a lot in our reports. But at the end of the day, and I learned this the hard way when I left DC and came back to Mississippi and had my policy degree from Hopkins, and I thought, oh, I know data. And I thought, all I need to do is show some data, package it in the right way, and you're going to believe us. You're going to vote the right way. Of course, you're going to support us, right? It doesn't work out like that. So I'm no longer naive enough to think that data in and of itself will change someone's mind, but you have to have good data. And when you align yourselves with medical professionals and doctors and nurses, and the other side didn't even go to college, which is what a woman who was recently almost put on our State Board of Health was, it really shows a big difference, and you have this credibility that no one else has. So please contact me if you want more information. My contact information is on the Women's Fund website, and I would look forward to talking to you. Thank you.
Thank you, Jamie and Anu and Heather. This has been a really great way for us to kick off this conversation, because we have 3 different organizations that are approaching this work. One is the repository for the best data we can get for both U.S. and abroad, and secondly, a focus on the big A word was IPOS work, and then Jamie and the work in Mississippi that portrays how a lot of the states in the U.S. are approaching this issue from adolescent sexuality and adolescent health. So, what struck out to me is that the data sort of presented this amazing constellation of dramatic issues that have been persistent. They're not new, right? The whole way in which women are continually unable to access and own the rights to care for themselves when it comes to their sexual health. And yet the policy issues that were lifted up by Anu show this huge disparity between the need that we keep putting forth from the data and the policy gap with what really women that continue to keep the barriers in front of us. So, what comes to my head is, why is this issue so tough? This issue that really was the cornerstone of the whole women's rights movement 45, 50 years ago, and well, actually longer if you go back to Margaret Sanger, right? But if you think of the modern contemporary movement, women's reproductive health was at the heart of it. And here we are, fast forward, 21st century, it's at the heart of our struggle. So to me, until we kind of overcome these barriers, all the other issues fall along the side of it in a way. So that's why I'm really thrilled that we're going to have, Cecile come up and wrap us up and really give us the way forward, I hope. But let me just say, what is the real distinction between approaching this issue as reproductive justice versus reproductive health? And is that part of the challenge we have as a network or a movement in articulating the core of the cause? You know what I mean? So is there a distinction? Is it a practical distinction, or is it a political distinction that we're making? And how does that affect our ability to frame the movement? Anybody can take that on.
Do you want to start?
Well, sure. So, and IPASS, because we work in such a diversity of contexts around the world, we use whatever works to have the conversations and create the partnerships that we need to advance our mission and advance the work that we're doing. So overseas, honestly, the idea of choice, and we had this conversation last night, really doesn't resonate. That's not really how people talk about the reproductive health issues and abortion around the world. So choice is not a word that we use in our materials or in our discussions. We approach the issue of abortion, and from a human rights perspective, not necessarily reproductive rights, but a human rights perspective, and then also from a public health perspective. Because that is what it is in the African context, in the Asian context. It is a public health problem. We also don't walk in the door and say, hello, we're here to talk to you about abortion. Mm-hmm. We frame and talk about the issue from wherever it is that people are. So for example, our work in Latin America, and we have many offices in Latin America, and as Heather noted, the laws are quite restrictive in Latin America. However, the laws do permit abortion in cases of rape. So we have worked in Latin America for years to say, so where are those services for women who have been raped? Where are the counseling services? Where is the emergency contraception? Where are the abortion services? And where are the constellation of services that women who have been raped need when they're in that situation? So that has allowed us to have a dialogue and a conversation with Latin American leaders about abortion and much more. So I guess in many ways, we think of abortion as being connected to everything else, and that's how we approach it and make those connections and those networks. So I think it is in some ways a political choice. It's a choice of what language, what words you're going to use in that moment that will resonate with your audience.
Mm-hmm. Thank you. Anyone else want to weigh in?
Our donors, if we said, help us fight reproductive justice, they would give us a blank stare. But if we talked about, don't you think women should have the right to plan their children, to really have access to birth control, and to really make those things more simplistic? Simplistic is the wrong term, but more real life. They definitely get it. And if we go around talking about LARCs as the next thing we want to focus on, they're like, what in the world is that? But if we say a lot of women don't use contraception consistently and correctly, and there's this new form, IUDs for teenagers or depot shots, they get that. So really framing it in ways that respond well to them. And one thing that's been really helpful, and I think everyone can access this, is WFN and Packard teamed up to develop some messaging around reproductive health rights and justice. And it's been really, really helpful for us. And I'm happy to share that work with you about different messages for different contexts for this work.
Thank you, Jamie. Heather, do you want to say anything?
Well, just to add, you all responded to the question in terms of messages, which I totally agree with. I've also noticed that there's kind of this discussion that's been happening within our community about what is a reproductive justice versus reproductive health versus reproductive rights organization. And I think that reproductive justice is the newest of the concepts, and it really does challenge us not just to think about choice and rights as a legal right to abortion, but really to think about, as I said, women's lives more holistically in terms of the social inequalities. It really does start to marry the social justice thought and critique with reproductive health and rights, and tries to merge those. So it's not just about preventing unintended pregnancy, but the right to bear children as well. And that has really been led by women of color in our community, saying that our lives are not just about preventing unintended pregnancy. We struggle with a lot of different issues. And so it really has been out of that kind of grassroots women of color efforts to say we need justice terms to describe our lives.
Thank you. And that leads me to this question, because your data presented so much, 50% almost of pregnancies among adult women being unintended. And I'm thinking about the link between unintended pregnancy and education as opposed to access. And I was struck by an article that Kavita Ramdas wrote in this Stanford Social Innovation Review. Kavita is a former CEO of the Global Fund for Women. And the article was titled, "What's Sex Got to Do with It?" And she says, girls are hot, reproductive rights are not. And so, after reading through, she talks about how, there's so much now in our space that's talking about investing in girls. Investing in girls is sort of the next answer for the 21st century, right? They're going to be the solution to economic development, health, accomplishments, eradication of disease, and so on. But it's sort of the magic bullet for the 21st century. And then, but what's still not able to be part of their education is education about their bodies and about sexuality. So the question, sort of like we have this sort of STEM versus sex ed. We have STEM all over the place. Everybody's advocating girls to get an education, math, and sciences, but there's nothing that says an educated 18, 20-year-old has a clue about how to prevent an unintended pregnancy, right? So how do we message this around education and the fact that can we approach this not because the girls lead to economic development, because they're human beings and it's a human right, which gets to your point about the justice frame. So I'm saying all that and not asking a question, but can we how should we start thinking more about the front end of this work, which is about just the basic, anything we want to do in this world, we promote education and knowing and getting equipped, whether it's science, math, or engineering. And yet our sexuality, we can't learn about it in the same way, so we can't manage it effectively. So I feel that there's this tension between that end and the adult end of women's sexual health and our rights. So I think maybe in the US it's more of a tension because there was such a push in the 90s around adolescent sexuality, and in some ways that might have influenced the regression on women's rights. So how do we need to think about the distinction between education for adolescents versus the full agency of an adult woman to have the ability to manage her sexual health? You want to take us on, Jamie?
So we commissioned some polling from Mississippi State University on sex ed in Mississippi, and all of these parents, 92% of all parents in Mississippi said, yes, I want my child to have sex education in the school district. It's huge. And then we asked more questions like, well, does that mean talking about birth control? 88% said yes. I mean, this is clear data that shows, this is what people support. But then we said, have you ever talked to your child about sex? 58% of fathers and 60% of mothers had ever talked to their child about sex. So for us, it's an issue of educating parents at the same time you educate teenagers. And so with our factnotfiction.com campaign, one of the key audiences was their parents. And we got more calls from upset parents than anybody else. And I'm thinking, we're targeting this at you. You are a target audience. They would call and say, why are you running these ads on radio, on country radio? And I'm like, well, so you'll listen, But really, one of our target audiences really was, the parents. And so we find that parents never got good sex ed. They don't know about their basic sexual health, and so they're unable to talk about that with their child. So really educating parents is huge.
Actually, that's a global lesson. That's true of sex education programs around the world. I remember visiting programs in Brazil, and it's the experience in Thailand also, where you're doing the sex education work with the young women and men, and the parents are listening around the corner. Because they don't know the answers either, and they really want to hear the information just as much as the children do. And the children are somewhat less, or the youth are somewhat less, they may not be absorbing it all, but the parents are really, they're getting it all, right? And so that's actually a global lesson, that it's an intergenerational learning process. And actually the global community has been doing a lot of work on youth, as we were discussing yesterday. I mean, on the planet, there's such a need to work with young people. There are so many young people now on our planet, the largest cohort ever, that the needs for youth are huge. And on our issue for abortion, it's very important, because the women that are dying, I forget the statistic, Katie, 47%, 48% of all abortion deaths are among youth. So the people that are dying, the women that are dying are young women. And so the more we can do to inform them, and I actually am moving away from the word education a little bit, and thinking about our panel this morning about digital information. It's information, especially that women and young women need, however they can get it. However they can get it, whether it's paper, whether it's online, whether it's texting, I don't really care. They need information, and when they need it immediately.
That's a great point. Heather, I don't know if you want to weigh in before I move on.
Well, another, by way of comparison, is a country like the Netherlands, which really does take its sex education very seriously, and it has among the lowest adolescent pregnancy rates in the world, and therefore one of the lowest teen birth rates and abortion rates. And what they do there is really weave sex education into other subjects and throughout the lives of young people. And so it begins very early with mostly even communications and relationships, and really thinking about normalizing sexuality. And as I said, whereas in the United States you might have this drop-in class for 5 hours in the 8th grade, and that's it. Throughout your education. This happens, whether you're in kindergarten or 3rd grade and 6th grade, age appropriate, increasing and changing over time what those topics are. And so by the time that you're an adolescent, all of this is not new or strange or uncomfortable. And as a result, young people in the Netherlands, when you ask a United States young person and you ask them about, say, condom use, and you ask them about whether they carry a condom with them when, in the event of having sex, they say, oh, I would never do that, I would be considered a slut, I would be considered fast or loose or looking for sex. But if you ask a young person in the Netherlands, they would say, well, of course I have a condom. I can show you it right here, because someone would be irresponsible not to be carrying a condom. So it's just a different framework because of that normalizing around sexuality.
Great, thank you. We're going to move to questions quickly, but I want to just ask the panel to weigh in on a lot of what we heard and learned, and we know from our experience, is that this whole sector is underfunded. This whole issue is underfunded from a variety of perspectives, and we've struggled a lot. There's been a whole lot of work, as you said, Jamie, earlier, about messaging. We kind of figure out we have to parse our language to even be able to raise the issue, and that still hasn't opened doors. So I wanted to ask just quickly, what are your thoughts about how do we involve unlikely partners in this effort? I mean, we're all the converted, right? How do we involve, for example, men more effectively in our issue? What would it take to identify and engage some unlikely allies. Have you any ideas or suggestions, anyone? And who are the unlikely allies?
Yeah, I mean, well, it's a really tough question. One of the ways that, well, so our Fact Not Fiction campaign has a marketing budget of $1.2 million, and it's from a donor that did not want to be named. And so lots of times in Mississippi, not lots of times, but this is just one really good example, you have donors who will want to fund this as long as they can kind of stay behind the scenes. And this is a Mississippi person who is funding this $1.2 million. And we were shocked by this, and we really did not even go asking for it. It really came to us. And so a lot of things like that happen. The other thing, though, about if there are any other national funders in the room, it's really hard. A lot of national foundations don't want to fund this work in the South because they don't think that progress is possible. Mm-hmm. So number one, you have to redefine progress. And number two, you have to show that progress is possible. And a lot of the work that we do, we work with organizations in DC, the National Campaign, Advocates for Youth, and they get money from national foundations to work with us. But we can't get money to do this work in Mississippi, right? So it's this kind of complex circle of events where a lot of foundations want to fund this work, but they don't want to fund it in Mississippi. They want to find a group in DC to help us do it. So a lot of it is really changing that conversation that we know this work well, we can do this work well, we want outside help, but we also want to be part of that discussion as well.
Thank you. Well, we're going to move to the audience, but I just want to say before coming to WFN, I worked in Georgia, and the mantra there was "Thank God for Mississippi," because we were always just one notch above Mississippi in all the data points. And speaking of unlikely allies, Jane Fonda was the chair of my board, and so in Georgia you have a Jane Fonda feminist leader and all of that, and in a very, very red conservative state. And so I would have, speaking of unlikely allies, we were doing this teen-friendly project in Georgia. We would set up 27 teen-friendly clinics around the state, by the way, with 159 counties. And I had a legislature call me once in the office and, "Michelle, I want to get behind you, but you got to give me cover," So this anonymity. And I think it's shameful that that's what it takes in certain environments, but I think that speaks to our need to really think deeply about this reframing from a point of view of human rights and justice, because the other way it just invites, I think, this parsing of ideology and fundamentalism and morality of loose women and all the other crap that comes with it. So I just wanted to
thank you, Michelle.
Give a shout out that Mississippi may have passed Georgia finally. So we're going to open up for questions, and we have how long, Jill? About 10 minutes for Q&A. So it's hard for me to see. So and we have runners with mics. Any questions? Right here in the front. Ariel?
First of all, I'd like
Wait for the mic, please.
Hi, thank you. This is a great panel. First of all, Article 19 of the Universal Declaration of Human Rights is our right to information and to disseminate information. So media, information, education all tie right back into the conversation. Mm-hmm. In particular, I'd like to bring up the issue of 2 votes, which were on the Mississippi ballot last election. And this is a reproductive justice issue. One of the ballots was about restricting abortion. Help me remember the details.
The ballots were personhood and voter ID.
Okay, and voter rights. Personhood and voter rights. And a lot of the groups that came into Mississippi worked on the personhood vote, and that got voted down, but the voter rights issue didn't get voted down. And so there's a contradiction there in our rights, and maybe you could speak to that.
So I'm glad you brought up personhood, because it's a fabulous example of how this issue works in Mississippi. So Planned Parenthood and the ACLU spent a lot of time and money in Mississippi to defeat personhood. They could not come in as Planned Parenthood and ACLU, so they set up this new organization, Mississippians for Healthy Families. And the whole the media in Mississippi was all about trying to figure out who is behind this, who's doing this, who are these people, and they never wanted to say who they were because of the stigma attached to being Planned Parenthood and the ACLU. And the tide didn't really turn on personhood until it became about birth control and in vitro, and the religious leaders started coming out of the woodwork to talk about it. So you're right that a lot of groups came in talking about personhood, but the irony is they could not claim who they were. And the other issue with personhood is that there are all of these people out there who got together and really were strong advocates voting because they wanted to defeat personhood. But what do you do with these people who don't have an amendment to vote down? It's not as exciting, just the legislative process. So how do you activate these people in Mississippi who clearly care and are very moderately progressive in ways that make sense? And that's the trick.
Thank you. Right here in the front. Here you go.
Thank you. So my question goes to, I'm Mashuda Khatun Shefali. I'm the president and CEO of Bangladesh Women's Fund. I represent here. So my question goes to all of three panelists. It is not only the abortion, and whatever the governments, policy and programs, including US governments and developing countries' governments imposing the contraceptives, uses for the women. And their choices and rights information are not being provided to the women. What kind of implications for using particular contraceptives, especially the implantations? Women mostly from the poor families and poor community, the women are kind of imposing to use this kind of contraceptives. And why still only the men has very little choice about the contraceptives? We don't know more than condoms are available for men to use it. So what could be done in these areas also to give the choice of women, to give the informations for women, so that women in different communities and different level of the world, they can really raise their voice how to exercise their choice, what kind of contraceptives they want and what are not. So what can be done, how this women community can be empowered and informed to raise their voice into that level as well. Thank you.
Yeah, contraceptive choice is a huge problem. It's particularly all over, really. I was going to say particularly in South Asia, but really it's true in sub-Saharan Africa also, where women essentially have the choice of one method, and men often have no choices. There is also vasectomy, you forgot to mention. There are condoms, and there is also vasectomy that is available for men. And in our work, certainly in South Asia, the issue is not always, do women have access to contraception, but is it coercive? Are they being coerced into accepting a method of family planning that they don't actually want? And that linkage also is present with abortion. And I think it's part of the stigma that is part of the work that we do in terms of abortion and contraceptive use. One of the things that we do in partnership with many others is working on commodity supplies. Because a big part of the problem is that there just aren't any methods there. They're just not available. So even though we know from our data that, or from global data that there's such a high demand for contraceptives, that there's such a huge unmet need for contraception, that women don't want to be pregnant, as Heather was saying, that increasingly family size is going down all over the world. There is not the method choice that's available to women. So what can be done? One is to work really at a much, I think, removed in some ways level about working on logistics and supplies and where are the commodities and why aren't they in the clinics. And the other is demand generation. Really sort of pushing and asking from your constituencies to demand where, I'd like other methods of contraception to be available. So I think it's, in some ways, it's a supply and demand problem, and they need to come together.
Michelle, we've had a hand up here for a while.
Excuse me? Okay.
Ok. Je m'excuse, je vais parler en français. Gisèle va traduire parce que sinon ça va être compliqué. Alors, bonjour. Okay, we have a center, women's center, and we give some help for women, planning education, dépistage volontaire pour le sida, les maladies sexuellement transmissibles et on soigne les victimes de violences sexuelles. Alors le problème que nous avons, c'est que la loi condamne les avortements. Le protocole de Maputo n'est pas appliqué.
Okay, the health center based in Bunia, in the northeastern part of DRC, in the Ituri territory. They work on family method for contraception. Also, they attend victims of sexual violence, and also women affected, women and also men affected by HIV AIDS. And the problem in her country, in DRC, is that the law condemns abortion, and the state of DRC has not adopted the protocol of Maputo.
Alors, MSF a installé le centre que nous avons maintenant et nous avons hérité le centre de Médecins sans frontières. MSF a apporté les méthodes contraceptives, donc les implants et tout le reste. Maintenant, MSF nous a cédé le centre. Les femmes veulent avoir les implants, mais MSF dit non, c'est trop cher, on ne va pas continuer à vous fournir les implants. Et là, nous sommes en difficulté avec les femmes parce que les femmes veulent avoir les implants.
Okay, so where they work, the center used to be run and is also run in part for the medical part by Doctors Without Frontier. And Doctors Without Frontier had introduced contraceptive, including implants. I don't know if it's a word in English.
Yes, yes.
But now that they have been trained and are doing, they are administrating the center that used to be run by the Doctors Without Frontier, they're telling them that now it's too expensive, the implants. So now the only thing that they can use would be the pills.
So the question?
La question, c'est maintenant, les femmes ne veulent pas avoir les pilules, c'est plutôt les implants. Alors, je vais terminer par donner l'expérience que nous avons vécue d'une femme qui était victime de violences sexuelles. Elle a eu des problèmes avec son mari, elle a eu la grossesse à partir de viol, et elle est venue vers le médecin pour dire « je vais avorter ». Et le médecin a dit « non, je ne peux pas te faire avorter, tu dois garder l'enfant, c'est le don de Dieu ». Et la femme a dit « soit je me suicide, soit vous me faites avorter ». Et le médecin nous a envoyé la femme. La femme est venue chez nous et dit « ou bien je me suicide, ou bien vous me faites avorter ». Et nous, on était devant un problème parce que la loi interdit. Mais bon, j'ai pris ma décision en dehors de mes collègues parce que tous les collègues disaient « non, c'est pas possible, il faut pas, c'est le péché si on fait avorter ». Alors j'ai parlé avec la femme, moi j'ai arrangé avec un médecin, j'ai fait avorter la femme, en cachette bien sûr, et on a arrangé la situation de la femme.
Okay. I'll do a resume, okay? It's she's telling a story about a woman who was raped by her husband. She went to see the doctor. She asked to be aborted. She told the doctor that if not, she will suicide herself. The doctor didn't want to do the abortion because it's illegal and told her to go at the Women's Health Center. And the woman was really, truly, she said, I'll commit suicide. So she even, Julienne took the decision to help that woman, and they proceed to interrupt her pregnancy. So that's where we are.
So the issue is that she's faced with a very tough choice. And because we're running out of time, we can't explore it further, but I think, Julienne, thank you for sharing the challenge that you're having when the Doctors Without Borders left, And so the implant left, and you now have a single choice, which is the pill, and also just continued barriers to the women accessing their rights. So we appreciate your question and concerns. We're really running out of time, and we have to wrap up. So please join me in thanking the panel for stimulating discussion. Thank you. And we're now going to transition to our final keynote presentation, and we're really, really excited to hear from our next guest. Thank you all.